I'd like to introduce you to the session moderator, Blythe Lord. Blythe is the founder and executive director of Courageous Parents Network, a national nonprofit whose mission it is to empower, guide, and support parents caring for children with serious illness and the pediatric providers that care for them. Blythe is also a founding trustee of the Cameron and Hayden Lord Foundation, a small family grant-making foundation whose mission it is to advance pediatric palliative care in the United States, as well as fund research of therapies for lysosomal storage diseases. Blythe's daughter Cameron and nephew Hayden died of Tay-Sachs disease in 2001. In the years following, Blythe has promoted the needs of families caring for children with serious illness and how providers can best meet these needs. She is an involved and vocal advocate for pediatric palliative care. Blythe received her BA in history from Yale and has a master's in education from Harvard. She lives in Newton, Massachusetts with her husband and 2 daughters. I'll turn it over now to Blythe. Thank you so much for joining us.
Hello, my name is Blythe Lord. Thank you for that introduction. I am delighted to be here with you today to talk about one of my most favorite topics, debunking the myths of palliative care and specifically pediatric palliative care. Joining me today is a woman I have come to know and admire very much, Michelle Moon. She is a doctor of osteopathic medicine, an adult neurologist, and she is now a fellow. She's receiving her fellowship in hospice and palliative medicine. I have come to know Michelle through my work with Courageous Parents Network, which we will get into in a moment, and Michelle will share her own story. We are really honored to be here with you today to talk about something that we both care passionately about, which is pediatric palliative care and how it makes such a difference in caring for a child who's living with a rare condition. Our learning objectives are to help to differentiate for you the difference between palliative care and hospice care, which is a very important distinction that is often misunderstood. To provide examples of pediatric palliative care from onset of diagnosis all the way through to end-of-life care, and to explain how palliative care is often appropriate beginning at the point of diagnosis, something that we can't stress quite enough. I think Michelle and I will really hope to convey to you that palliative care is much more about everything that happens before end of life, and hospice is really about what happens at end of life. But I'm jumping to one of the highlights, and that will be Michelle's, much of what Michelle will share with you. My story began in 1999 when my daughter Cameron, there in the Red Crown, was only 5 months old. She's my second daughter. Her older sister Taylor was at the time 2 years old. And when Cameron was a little over 5 months old, her first cousin, my husband's identical twin's son, was diagnosed with infantile Tay-Sachs. Infantile Tay-Sachs is always still, unfortunately, fatal in early childhood. It is a rare genetic condition. It's a lysosomal storage disease. And both parents have to be carriers, and the child receives the mutation from both parents. This is a story that will be familiar to many of you. Not my story, but the phenomena of autosomal recessive genes. And when my husband's nephew, but my husband's biological nephew, Hayden, was diagnosed with Tay-Sachs, we went online to read about it, and I learned that both parents have to be carriers. My husband is an identical twin, so I assumed that if his brother was a carrier, it was likely that my husband was a carrier. And the at-risk population for Tay-Sachs, one of the populations is people of Ashkenazi Jewish descent. And I knew that my paternal grandmother fell into that population, so that it was not out of the question that I too would be a carrier. I also read about the early symptoms of Tay-Sachs, and one of them is pretty much one of the only early indicators is that the children have not outgrown their infantile startle response. And I knew for my older daughter, Taylor, what that startle response looked like and when it abated. And I saw that in my second daughter, Cameron, it had not abated. She had just received a glowing bill of health from her primary care pediatrician. And I went to who thought it was unlikely that she had Tay-Sachs just because of how she was presenting, but these were very early days. Children are not typically diagnosed so early. And I went and we saw a medical geneticist and who said that the likelihood of these two children in our family both having infantile Tay-Sachs was extremely unlikely, and we hoped it was a false positive. Well, they took my test. It came back that I was a carrier. The hope was that it was a false positive. We went and had my daughter tested, and it came back that she was, in fact, affected by Tay-Sachs. There was no evidence there was very little evidence of hexa activity in her blood. So within 2 weeks, we had learned that these two beautiful children, my nephew and my daughter, were both going to die early in childhood. And what happened to us was really extraordinary because we traveled that road with my brother and sister-in-law. Most families do not have somebody so close so close to them to do this journey, this very isolating, difficult journey together. But my husband, Charlie, and I had my brother, Tim, and sister-in-law, Allison, who happened to be my roommate from college, which is its own story. But we were very close already, and this just made us closer. And in doing that work together and having conversations about what our goals and what we wanted for our children, we were able to process together the grief we were experiencing and also think about what our goals of care were. Conversations around feeding tubes, how we felt about hospitalizations. And while it would have been fine if we had made different decisions for our children, it turns out we made similar decisions, ultimately with my daughter, because infantile Tay-Sachs takes so much away from these children, and there was no hope of any curative gene therapy on the horizon the way there is now. We felt that prolonging her life through artificial nutrition was not in her best interest. And we ultimately decided and worked with our daughter's primary care pediatrician that we would not interfere, not deliver artificial nutrition through a G tube. And we worked with him to make sure she stayed very comfortably at home all the way through her life. He helped us manage her seizures at home. He helped us manage her pneumonias at home. And I raise this because he was just a primary care pediatrician. He was not trained in palliative care. In 1999 and 2000, pediatric palliative care was a burgeoning new field. Adult palliative medicine was an established field, but pediatric palliative care really was not. But what he did as a primary care pediatrician was really just practice the fundamental skills of palliative care, which was communicating with us about what our care goals and values were, what we wanted for her, doing anticipatory guidance, helping us know what some of the milestones that were coming, and helping us anticipate what those shifts in baseline were going to be and the decisions we were going to have to make when we arrived at those shifts in baseline and think about what we wanted. In addition to goals of care conversations, he arranged for our older daughter, to get a grief counselor. He helped us find a neurologist who helped us manage her seizures at home. And when she did transition to end of life, he was able to help us keep her at home. He knew that our goal was for her to die at home. And he really did that work all the way along with us. And it was only after, when I was reflecting on the very, very positive experience that we had had, that I understood that what he had done was really practice palliative medicine. And that was part of what drove me to this work. Is I was like, okay, I want other families to understand what palliative care is and what a difference it can make. It is also the case, and it's an important point, that we were, my husband, Hayden, because he was a year older than my daughter, Cameron, Hayden died 5 months before she did, and my husband was present for Hayden's end of life and was able to tell me what it looked like. And the firsthand account, and the fact that Charlie was able to tell me that Tim and Allison were able to keep Hayden comfortable at home with the help of Hospice, really made me see that we too could keep our daughter at home comfortable. And it deactivated a lot of the anxiety and dread I had about her end of life. So the firsthand account from my husband, plus the involvement of pediatric palliative care from my daughter's pediatrician, really made a significant difference in our experience. And it was that led me several years after her death to start Courageous Parents Network. Courageous Parents Network is a web and mobile platform available 24/7 to help orient, empower, and accompany parents and pediatric providers who are caring for seriously ill children, many of whom have rare diseases. We feature a library of almost 600 videos and dozens of podcasts and downloadable guides and blog posts featuring parents and providers who are providing insight and guidance to help families feel less alone, make decisions, feel empowered as decision makers, feel that they have the information they need to make the best decision for their child, and ultimately build their confidence in doing this extraordinarily difficult work in caring for a seriously ill child and giving what every parent wants for their child, which is the best life possible for as long as possible, whatever that means to that particular family. My background is in video production and distance learning before I started Courageous Parents Network, and I was able to put that together in creating this. We launched in 2014. We're 7 years old now, and because of everything we've been learning and hearing from families affected by, whose children have been affected with and living with and thriving with, and in some instances dying from these rare diseases, we are building out a really rich library of materials to help parents. And again, videos, podcasts, downloadable guides. Anyway, it was in this work, in doing this work, in this journey, that I met Michelle. I had first read about Michelle on CNN.com, which had her and her extraordinary journey, or rather her journey with her extraordinary daughter, Juliana. And I reached out to Michelle to offer encouragement and support for what she and Juliana were doing, what she and her husband were doing with Juliana. And ultimately then, several years later, Michelle came back and we had a long conversation, and I interviewed her about Juliana for Courageous Parents Network. And Michelle's story, Juliana's story, has subsequently become really a very meaningful addition to what we offer, because there's so many extraordinary parts of Juliana's story and Michelle herself. So without further ado, I will pass this over to Michelle to begin.
Yeah, so one of the points that Blythe and I really want to drive home today is that palliative care works best when it's delivered early. In a perfect world, we wouldn't need it at all because we wouldn't have these horrible illnesses, certainly not in children. In a more perfect world, it would be delivered at the time of a diagnosis of any serious illness. But we all know that our world is really far from perfect. And I think when it comes to palliative care, at least, part of the issue is that even the medical community, by and large, doesn't really understand what it is and what it can do. And so that is, I'm really happy to talk about that. And I think my story kind of illustrates that. So I'm a neurologist, and very ironically, my daughter had a really horrible neuromuscular disease. Her name was Juliana. Her disease was Charcot-Marie-Tooth disease, or CMT. It is a rare disease. It's a hereditary neuropathy. And so what that means is that the nerves that supply our muscles don't work very well. So the main symptom is weakness. It is not known to really be a fatal disease. It does cause a lot of disability, but it's really, again, it's not known to be something that takes lives. However, it's caused by there are over 100 different gene mutations that cause it, so the severity is actually variable. It can be almost asymptomatic. It can be horrible. And Juliana had the horrible kind, the worst case I'd ever seen, the worst case that many people had ever seen. In her, it really looked like ALS in a toddler. So it's very much a double-edged sword. I always tell people, being in the situation where you know so much about what's going on, it was good because I could be proactive, but then it was bad because I knew things and I worried a lot. The thing I worried the most about was breathing problems, because breathing problems and feeding problems are really the things that end up killing people with neuromuscular disease. We got the diagnosis when she was about 18 months old, and so I took her to a pulmonologist shortly afterwards to make sure that we were doing everything we could. We started using oxygen at night. We had her get a tonsillectomy to open up the airway, and we hoped that would help. But very shortly afterwards, she had her first hospitalization for respiratory failure. It was really scary. She just had like a runny nose, and then we ended up in the ICU. And this would become our pattern for the next 2 years. This was way before COVID, but at the time, we were stockpiling hand sanitizer. We were wearing masks. We were paranoid about germs because every time she caught a cold, we ended up in the hospital. These were very difficult hospitalizations. She would get these respiratory treatments around the clock. She would have to be awake for them, and they were really tough. They were really tough to watch. They were tough on her. Every time we would go into the hospital, there would be a new treatment, a new medicine, something we would try that was supposed to keep us out the next time, but it never worked. The worst part about this, and this is something I've heard from other parents who have children with progressive disease, is the regression. Every time we got out of the hospital, she would come out with a baseline that was worse. And that's just really painful to watch because it's just the opposite of how things should be. So in particular, the year that she turned 3 was the worst. We were in the hospital 3 times that year. She started out that year able to take a few steps in the walker, just like you see in that middle picture there. And by the end of the year, she couldn't even sit up on her own. Her breathing also became really, really compromised. So by the end of that year, she needed BiPAP all of the time. If you don't know what BiPAP is, it's very similar to CPAP. It's that machine, that respiratory device that people with sleep apnea wear. It's a mask that covers your nose and sometimes the mouth. It forces air into your passageways and keeps the airways open. So it's a pretty high level of respiratory support, and she ended up needing that all the time. That 4th hospitalization, which was her last hospitalization, felt really different from the other ones. I had been worried for a long time that she wasn't going to make it, but it's such a horrible thing. I couldn't talk about it. I couldn't even think about it. I suspect that our other doctors had been thinking about it as well and were worried about it, but no one was talking about it until that last hospitalization. We were offered a palliative care consult, and at the time, I really didn't know what it was. I thought that they were people who would sign us up for hospice if that's what we wanted. But they were described as a team that could just really support us during this difficult time. And I thought, we really need help. Why not? At least I'll meet them. And what I remember from that first meeting, I'm so glad that we said yes, is that they just listened to everything. So we spent a lot of time talking about Juliana's disease, but more importantly, we talked about her. I mean, we talked about what an amazing child she was, what was important to her, what we were hoping for. We talked about us. We talked about how lost we were, how hard things were at home, how we didn't know what we should do next, just all of that. And it is really difficult to describe just how comforting that was, just to lay it all out there. And I think it's not that Juliana's other doctors didn't want to talk about these things or be that kind of support for us, but it really is a matter of time and context. I know this very well as a practicing physician. When you have 15 minutes in the office or 10 minutes on rounds, you talk about labs, you talk about medications, there's an agenda you have to follow. But with palliative care, the agenda is you. It's the patient as a person, it's the family, it's learning about you and whatever you need to get support. And it's a powerful thing. One of the main things that the palliative care team did for us right away was start coordinating care for us. And so, yeah, I'm a doctor. I know how to talk to other doctors. I know how to get what I need from insurance companies. But when you're dealing with that kind of illness in your child, it's just overwhelming. So the palliative care team really could lift this heavy burden for us by just coordinating care, making sure that all the teams were on the same page and just getting things done for us. And the only reason they could do that is because they had taken the time to get to know us and they could represent us. And that's really kind of at the core of what palliative medicine is. We did have a care conference. Her doctors, they told us that kids like Juliana, they could live for years on BiPAP as long as we were able to keep her healthy. Sometimes you could just catch a stable period and go with it. On the other hand, she was so fragile that everyone could see that her next hospitalization could very easily be her last. So we were offered hospice. And my reaction to hospice was like most people's. I really had, who wants hospice? I wanted nothing to do with it. On the other hand, I recognized that we really needed help. So we ended up going into hospice. So I'm going to talk a little bit about that because there are some misconceptions about hospice. So what hospice is, your main point of contact in hospice is a nurse who comes to see you regularly, usually once a week, but more often if needed. And that nurse really becomes, they get to know you. They help you with everything you need in terms of medications, equipment, and that kind of thing. Hospice does not give you ongoing nursing care. So that's one of the misconceptions. It's not 24/7 nursing care. There is like a medical aid that will come a few days a week for a few hours at a time, but it's not ongoing. But there's a whole team of people to support you. There's a chaplain if you want. There's a social worker. There are grief counselors because what hospice and palliative care recognizes is that illness is not just physical. It affects every facet of your life, and it's a family. It doesn't just happen to a person. For us, the most valuable thing about hospice is that we had 24/7 access to a medical team. So if something happens in the middle of the night, you can call and a nurse or a physician will answer and help you with whatever you need. The idea is to keep you out of the hospital. And so that's really why we signed up for hospice. And I'm really glad we did. So if we could go to the next slide. One of the other big misconceptions about hospice is that it's giving up. And it's really, really the opposite of that. Our medical treatments.
Michelle, can I just interrupt you? I think that palliative care, the misconceptions of hospice and palliative care is that if you refer to palliative care, it means you're giving up. That's not what we mean.
That too, you're right. I think people think palliative care in and of itself is that you're giving up, and that's very true. But it isn't. In hospice, in particular, when we were doing hospice, or when we were in hospice, the treatments, the things that we did really didn't change a whole lot at all. We did all our treatments, we did our medications, but the difference is you think about it more. You think about everything for us was through the filter of what was important to Juliana, what were we trying to do, and that really is kind of palliative care as a whole. You just think about what is the big picture, what are the goals, and so that carries through over into hospice as well. So in our case, we entered hospice I think in November, and I wasn't sure that we would make it through the winter, but we made it through that winter and we made it through the next winter, and it was 18 months total, and it was a good 18 months. So those pictures there, not every day looked like those, but many of them did. She had visits from princesses and mermaids. She learned to read. She was a child, so we just played. And so that's what our life looked like. And I'm really convinced that this wouldn't have happened if we hadn't made that switch and really started thinking about where things were going, what was important to Juliana, and just giving her more to live for, quite frankly. So Juliana died 5 years ago. and everything changes when you lose a child. I think the thing that I've seen most from bereaved parents is that we need purpose. We need to spend our time doing things that really matter, and palliative care really matters. And so I also changed careers just like Blythe did. I'm a neurologist. I've been practicing for over 10 years, but I decided to leave and go back to training and do a hospice palliative medicine fellowship. It's not really an easy thing to go back to training after you've been out for so long. We had to move our family. I had to leave my patients, but I'm really, really glad I did, because it's really been the most rewarding year in medicine for me. And so one of my life's missions, just like Blythe, is to kind of spread the word about palliative care and help people get more of it. So I'm really glad we get this opportunity to talk, and I'm going to end by talking a little bit more formally about palliative care. So if you can go to the next slide. So palliative care, simple definition, it's specialized medical care that treats the symptoms and stress of serious illness, and its goal is to improve quality of life. Palliative care can be hard to describe sometimes. That's one of the first things we learn in fellowship is how do we explain it to people? I think one of the reasons it's really hard to explain is because quality of life is different for everyone. For some people, it means getting as much time as possible because they want to be with their family. For some people, it's to be able to do certain things, to go somewhere, to be able to eat, to be able to ride a motorcycle. It just depends really on the person and the family. So it can mean a lot of different things, and it can encompass a lot of different things. And I think that's why it can be hard for people to understand. But what I tell people is that we try to make you live, just like Blythe said, as long as you can, as well as you can. Next slide, please. So it releases symptoms and stress of illness. So sometimes we focus a lot on physical symptoms. So things like nausea, pain, shortness of breath, those are common symptoms that people with serious illness deal with. And these can really, really affect your quality of life. And so sometimes that is what we focus on. We really try to aggressively go after these symptoms. But we all know that the physical part of illness is just one small part of it. There's emotional distress, there's spiritual pain, there's social isolation, there's economic stress. And so that's why palliative care is really, it's not one person, it's delivered by a whole team. If we go to the next slide, palliative care really requires an interdisciplinary team. It's doctors and nurses working alongside social workers and chaplains, in pediatrics, of course, child life specialists, and it's all about the patient, surrounding the patient and that family with support and whatever they need. It really is a team sport, and that's really that's been one of my favorite parts about making the career switch, just because no one person really has the ability to help with everything that a family needs who's going through this kind of stuff. So you really do need a big team, and the people who are in this work really want to be in this work. So it's really, that's one of the best things about doing this. Next slide. Palliative care can be delivered at any stage and at any age of anyone who's dealing with a serious illness, and it can be provided alongside with curative treatment. This is probably the number one misconception about what palliative care is. So that top figure is what most people think of. So basically, you get a bad diagnosis, you treat the disease, you treat the disease, and finally, when you and your doctors decide that there's really no good treatment left, then you bring in palliative care, and then you go into hospice. Really, though, it's much better if we follow that second figure, where you get a bad diagnosis, palliative care is introduced at the time of diagnosis, because it's incredibly stressful when it's like a bomb that's dropped in your life. And so to have palliative care from the very beginning is extremely helpful. In the beginning, in most diseases, there are more treatment options directed at the disease. So you may focus most of your time and energy on those options. But later on, if it is a progressive disease and there are less good treatment options, palliative care takes a bigger role. And then hospice care is simply palliative care at the end of life. It's very specific. And I have to add, too, that for pediatric illness, you don't always get to hospice care. Many times the disease is not a fatal disease. There are rare conditions that aren't fatal. Some of them can be cured. So sometimes doesn't always end up in hospice. But for the people who do, when the disease is fatal, that's palliative care just at the end of life. And hospice care goes beyond even death with bereavement services for a year after death. So really it works much, much better if we follow that new model. And that's what so many people are trying to get the word out and trying to make people understand, the medical community and patients, just what it is and what it can do. And that's really all I have. Thank you. I'm very thankful for this opportunity to talk about it.
I think based on what I just heard Michelle say, she made a very, very important point about how palliative care certainly is not just for people who've been diagnosed with fatal conditions. It is any serious illness for which that extra layer of support, that interdisciplinary team, would be helpful. And for example, when a child is diagnosed with a serious illness, there are siblings to take into account. And that's where a child life specialist can be really helpful. Palliative care, if you live somewhere where it can be delivered, where there are providers who will come into the home, the palliative care, and oftentimes that's where the family prefers to be, especially if children are not in an acute moment. They're living at home. They're going to school if that's an option. They want to be in their community. They want to be living with their family in their home. Palliative care can come into the home as that interdisciplinary team. It could involve, child life that does activities with the child or with the child's siblings. Sometimes it's music therapy. Sometimes it's massage. I've been at this for a long time, since my daughter's death in 2001, and I've seen the field grow, and I know that the availability of pediatric palliative care in hospitals, whether it's a freestanding children's hospital or a children's hospital inside a large hospital, that most hospitals now have one or more people who are palliative care, who are trained in palliative care. And what I think is a really important thing to convey here is that you may have your child's primary specialist, whether it's a neurologist or an oncologist, may not be thinking of making a palliative care referral for you, because they themselves may think that palliative care is really for end of life. And in that moment, they are doing you a disservice. And I would encourage you to ask your child's specialist, your lead person, pulmonologist, neurologist, whatever, GI, whatever it is there somebody in this hospital who practices palliative care, a palliative care clinician? And if so, I would like may I please have a consult with them? It's a referral service, and you need to be referred to palliative care. And if they say, well, your child's not at end of life, why do you need it? You say, no, this is not about end of life. This is about me wanting to focus on quality of life, and me wanting to talk to somebody who has the time. As Michelle said, a lot of these specialists don't have time to talk about goals of care and the big picture and the whole family. Whereas a palliative care nurse or doctor or social worker, that is what they are there for.
So I think all your points are excellent. Really, palliative care is standard of care when you're dealing with these illnesses, and I think that's maybe part of the shift of what has to happen. Where if people and medical providers, if you just realize that for these diagnoses, especially lifespan limiting ones or serious illness, this is really standard of care. It's what should be done. It should be offered. And I will make one point. It's a little adult palliative care and pediatric palliative care. There are some differences, and one of the differences is With adult palliative care, we really do focus on patients who have lifespan limiting illnesses. So there are a lot of serious illnesses that profoundly affect quality of life, but are not lifespan limiting. And in the adult palliative world, we see people really who have the lifespan limiting illnesses. In pediatrics, it's different. There are pediatric diseases that are devastating but still curable, or that people can live with into adulthood. So they may not be lifespan limiting, but they're serious. And that palliative care is kind of more inclusive in the pediatric setting. And so I just want to make that point because that is a little bit different. And Blythe is absolutely correct. I love it when we get patients that they're there because they ask for us, because, again, we have work to do. The medical community doesn't know about palliative care enough right now. So please don't be afraid to ask for a consult.
Yes. I've in my work at Courageous Parents Network, I've interviewed families who have said, I wish I'd known about palliative care sooner. I wish I'd been referred to palliative care. We interviewed a dad who said, when palliative care came into the room, I told them to go away. And I wish I hadn't told them to go away, because when we eventually got it, I don't know, something like 8 weeks later, and palliative care helped us go home with our child and live well, I realized I wish I'd had this sooner, because this would have helped us make that transition home and focus on quality of life at home sooner. Let's watch. This is an example. This is a palliative care doctor on the right. That's Dr. Pat O'Malley, talking with two parents, Jennifer and Stuart Seidman. Their son, Ben, had MPS, Sanfilippo syndrome, which is MPS 3, I think it is. And Pat O'Malley was their son's palliative care doctor. And here they are talking about how palliative care helps with difficult decisions. I think we have just enough time for this.
Funny how the world makes so many assumptions. When you have a medically complex kid, all the medical community assumes that it's the responsibility of your pediatrician, but your pediatrician is really pulling back from you because they have less and less to do with you because you're not a typical kid. And there's this huge hole that doesn't really get filled. It gets missed between all the specialists that you see.
And we knew that palliative care is different than hospice care. We knew it wasn't an end-of-life engagement. It was, from our perspective, a way to help us make decisions and what can we do to make Ben's life most comfortable, make him more comfortable.
For example, we eventually stopped giving Ben swallow studies because we knew his swallowing was going away. The study was only telling us that. It was only giving, quite frankly, school systems ammunition to why he couldn't do something instead of us, which is he can still do something. And so we stopped having them. There wasn't a purpose that was making his life better unless we wanted to choose a feeding tube. And that's a different conversation than just a swallow study. I mean, we knew he was aspirating. We knew we needed to puree everything. We knew we needed to modify how we were feeding him. We didn't need a test or him to have to go through that.
It was actually such a perfect use of palliative care to essentially to create a space where you can examine what next steps are. And you two came already with a language about talking about them, a philosophy of care. You were very clear that you wanted to do those things that would help the quality of his life.
I thought that was something you helped us with a lot, was to be able to translate our philosophy into a language, into a conversation with the medical field. on how we wanted to approach Ben's care.
We were trying to decide whether we were going to fuse his spine, and as Stuart said, we wanted to get all those doctors in the room to say, okay, if we fuse his spine, what's the impact on his GI tract, and all the things that are making up Ben, and have the doctors be aware of the impact, the surgeon to be aware of the impact of the spinal surgery on his GI tract, on his thing. And I know they can kind of think about it, but when you sit down and you put a face on it and you have a full-on conversation, it's much different than sitting with a chart. And I think palliative care made that happen.
So I think the palliative care role, again, is not so much to be directive, but to say, well, here are some of the good questions that we should examine so that we can figure out together what makes the most sense.
Palliative care could hear through it and talk about it medically, talk about it emotionally, talk about the physical changes that Ben's body would go through. That's a lot to put together into one package, and it's so helpful when it's filtered down for you a little bit, because your emotions are, I don't mind around the topic, as I said, just because I'm the mother and it's my job.
So what I love about that video is how Dr. O'Malley and the parents, Ben and Stuart, talk about how palliative care helped them with difficult decisions around such things as the feeding tube, which I will just, my pet peeve, if I may, is there's nothing that upsets me more than when I hear a family tell me that they've been told that their child needs a feeding tube or needs spinal fusion surgery. In the world of autonomy of the patient and autonomy of the family, these are things to consider, but very few things are mandatory or necessary. It may turn out that in terms of what you want for your child or family member's quality of life, that intervention is necessary to help you achieve your goals. But in and of itself, none of these interventions all by themselves are necessary outside of the context of what matters to you. And I think that is one of the most important things that palliative care can do.
It's kind of ironic. One of our big messages is palliative care really should be delivered early. You got it early. I did not, and I'm a physician. And that's ironic. It's because I didn't know. And again, we've said this many times, people just don't know, including the medical profession. And so just also in terms of CPN, one of the really special things about it is that it equally serves well patients and families and the medical community. There's so much to learn. It's input from, again, professionals and patients and families who are dealing with it. So that's really unique. You don't find those kind of resources. Usually it's either, for doctors, for patients, but CPN really blends it. And so I think it's, that's one of my favorite things about it. And I think it's really kind of, that's what we do with palliative medicine. It's everyone's input, and it's about the patient. And so I also wish I had known about CPN long before I knew what it was. So thank you, everyone.